Hello, my name is Donna Edwards, and welcome to Addiction Counselor CEU. We're going to be discussing mood disorders. Most people with a mood disorder experience only depression. This pattern is called unipolar depression. Person has no history of mania. Mood returns to normal when depression lifts. Some people experience periods of depression that alternate with periods of mania. This pattern is called bipolar disorder. How common is unipolar depression? 1 year prevalence, 9%. A lifetime prevalence is about 18%. 26% of women versus 12% of men. In almost all countries, women are twice as likely as men to experience severe unipolar depression. How common is unipolar depression? Prevalence rates similar in Canada, England, and France. Approximately 85% of people with unipolar depression recover, some without treatment. Around 40% will have at least one other episode of depression later in life. Diagnosing unipolar depression. Major depressive episodes marked by 5 or more symptoms, including sad mood and/or loss of pleasure, lasting 2 or more weeks. In extreme cases, symptoms are psychotic, hallucinations, delusion. No history of mania. Symptoms: emotional, extreme sadness. They feel miserable and empty. Some are agitated and angry. Many have anxiety. Motivational loss of interest is usual activities or normal activities, socializing, sex, hobbies. Behavioral: move and speak slowly, stay isolated or in bed all day. More symptoms: cognitive, negative views of themselves, thoughts of hopelessness or helplessness, bias in attributions. Physical: disturbance in appetite and sleep, headaches, indigestion, constipation, fatigue, dizziness, general pain. Additional specifiers and categories: melancholic, failure to respond to any pleasurable event. Seasonal depression, changes with the seasons. Catatonic, marked by either immobility or excessive activity. Additional specifiers and categories: postpartum depression occurs within 4 weeks of giving birth. 10 to 30% of new mothers have postpartum depression. May actually begin during pregnancy, also called peripartum depression. Note: different from postpartum blues, milder and more common, affects as many as 80% of women. Other depression disorders: persistent depressive disorder, repeated major depressive episodes for at least 2 years. Premenstrual dysphoric disorder, diagnosis given to women who repeatedly experience clinical significant depressive related symptoms the week before menstruation. Unipolar depression, biological view, genetic factors, family pedigree, twin adoption, and molecular gene studies suggest that some people inherit a biological predisposition. Researchers have found that as many as 20% of relatives of those with depression are themselves depressed, compared with fewer than 10% of the general population. Unipolar depression, biological view, genetic factors. Twin studies demonstrate a strong genetic component. Rates for identical MZ twins 46%. Rates for fraternal DZ twins 20%. Biochemical factors, neurotransmitters. Neurotransmitters, serotonin and norepinephrine. In the 1950s, medications for high blood pressure, Respirin, were found the cause of depression. Some lowered serotonin, others lowered norepinephrine. This led to discovery in effective antidepressant medications which relative depression by increasing either serotonin or norepinephrine. Depression likely involves not just serotonin or norepinephrine. A complex interaction is at work, and other entities may be involved. Biological factors of hormones. The endocrine system, hormone release. People with depression have been found to have abnormal levels of cortisol released by the adrenal gland during times of stress. People with depression have also been found to have abnormal melatonin secretion. Model has produced enthusiasm but has significant limitations. Relies on analog studies. Depression-like symptoms created in lab animals. Do these symptoms correlate with human emotions? Unipolar depression, physiological views. The psychodynamic view, link between depression and grief. When a loved one dies, the mourner regresses to the oral stage. For most people, grief is temporary. If grief is severe and long-lasting, depression results. Those with oral stages issues, unmet or excessively met needs, are at greater risk for developing depression. Some people experience symbolic, not actual loss. Newer psychoanalysts focus on relationships with others, object relation theorists. The behavioral view. Depression results from changes in rewards and punishments people receive in their lives. As life changes, we experience a change, loss of reward. Research supports the relationship between the number of reward received and the presence of depression. Social rewards are especially important. The cognitive views. Negative thinking. Beck theorized 4 interrelated cognitive components combined to produce unipolar depression. The first one was the maladaptive attitudes. Self-defeating attitudes are developed during childhood. Beck suggests that upsetting situations later in life can prompt further rounds of negative thinking. Secondly, this negative thinking often takes 3 forms called the cognitive triad. Individuals repeatedly interpret the first their experiences. second, themselves, and third, their futures in negative ways, leading to depression. Depressed people also make errors in their thinking, including arbitrary interferences, minimizing of the positive and magnification of the negative. Depressed people experience automatic thoughts, a steady train of unpleasant thoughts that suggest inadequacy and hopelessness. Other cognitive views. Learned helplessness. There has been significant research support for this model. Human subjects who undergo helplessness training score higher on depression scales. Other cognitive views. In recent versions of the theory focused on attributions, internal attributions that are global and stable lead to greater feelings of helplessness and possibly depression. An example is, it's all my fault, internal, I ruin everything, global, and I always will, stable. If people make other kinds of attributions, this reaction is unlikely. An example is, she had a role in this also, which is external, but I have been a jerk lately, which is specific, and I don't usually act like that, unstable. Social cultural view. Family social perspective. Research is constantly linked depression to factors such as unavailability of social support, isolation, and lack of intimacy. How are culture and depression related? Depression is a worldwide phenomenon, but the experience of symptoms differ from culture to culture. For example, Westerners report more physical rather than psychological symptoms. As culture become more Western, symptoms shift. How do gender and race relate to depression? Rates of depression are much higher among women than men. One social cultural theory holds that the complexity of women's roles in social leaves them particularly prone to depression. How do gender and race relate to depression? Few differences have been seen overall among Caucasians, African Americans, and Hispanic Americans, but striking differences exist in specific subcultures. In a study of one Native American village, lifetime risk was 37% among women, 19% among men, and 28% overall. These findings are thought to be the result of economic and social pressures. People with bipolar disorder experience both the lows of depression and the highs of mania, characterized by dramatic and inappropriate rises in mood, shifting back and forth between extreme moods. A number of sufferers become suicidal. That is bipolar disorder. Symptoms of mania. 5 main areas of functioning may be affected. The emotional, which is the mood of euphoric joy and being out of proportion to actual happenings in a person's life. Also moods of irritability and anger when other gets in the way of exaggerated ambitions. Motivational, what context, excitement, involvement, and companionship. Little awareness that social style is overwhelming and excessive to others. Symptoms of mania with behavioral is very active, move quickly, talk loudly or rapidly, cognitively show poor judgment or planning, and physically high energy level, often in the presence of little or no rest. All right, bipolar 1 diagnosis is marked by full manic episodes lasting at least 1 week and including abnormally high or irritable mood, increased activity and energy, and at least 3 other symptoms of mania. Also includes major depressive disorder. Diagnosing bipolar disorder. Bipolar 2 disorder, marked by mildly manic, hypomanic episodes and major depressive episodes. Hypomania, an elevated mood state but not severe enough to cause major disruption in normal functioning. Some people with this pattern are able to accomplish huge amounts of work during mild manic periods. What causes bipolar disorder? Neurotransmitters. This apparent contraindication is addressed by the permissive theory about mood disorders. Low serotonin may open the door to a mood disorder and permit norepinephrine activity to define the particular form the disorder will take. Low serotonin plus low norepinephrine equals depression. Low serotonin plus high norepinephrine equals mania. Genetic factors. Some people may inherit a biological predisposition to develop bipolar disorders. Family pedigree studies support this theory. When one twin or sibling has bipolar disorder, the likelihood for the other twin or sibling increases. Identically twins, which 40% likelihood, fraternal twins and siblings 5 to 10% likelihood, the general population 1% likelihood. Abnormal brain structures. Smaller than average basal ganglia and the cerebellum. Lower volumes of gray matter in the brain. Structural abnormalities in the amygdala and the hippocampus and prefrontal cortex.